isolated systolic, elderly, youngsters, primary MI, strokes, it works everywhere. In CKD stage 4 and 5, it works, but as of now, the guidelines do not allow us to use it when the EGFR is important. And is it a sustained BP reduction? Yes, because this, what is the renal denervation that we are using now does is, it just strikes the axonal component of the nerves. Once the axonal damage is there, it's permanent. So this is unrecoverable, so there is no question of a temporary benefit. The data shows that even up to the sustenance of benefit is up to there. 10 years data is there now. 10 years the BP reduction is very good, and you see here, as the time goes, the BP reduction gets bigger and bigger and bigger. International experience also is the same. If you go by the patient preference, this has been discussed before. The patients seem to be identical. This you ask by questionnaires, many of them seem to be preferring the strategy of BP reduction, which is an adjunctive one. It doesn't replace the first and second pillars, of course. Many people like at least this component to be on board in them instead of taking multiple drugs forever. Other systems are there, ultrasound-based paralyze, alcohol injection-based peregrine system, but probably the one which is most useful is the simplicity spiral catheter, because it just affects the sympathetic nerves in the periadventitial space, and it can go down up to the branches up to the renal border, which the other systems cannot. So in summary, true resistant hypertension is a big problem. You will be seeing the lots of these patients in your clinical practices. You need to think of the third line of third pillar or third line of MACE reduction in your practice. If you find such a patient and if you have ruled out all your secondary causes, you should think and then refer off to centers where we are able to do this RDM. It's a very effective strategy, smart, 24-hour control, safe control, durable, sustained BP reduction, and always on effect is there. Useful both in resistant hypertension and those patients where medication intolerance is there. A co-management strategy, identify these patients, refer off, get RDM done, and then of course they come back to you and then you manage them for a long time. And shared decision making, explain the pros and cons of the procedure to the patients. And fortunately in our country, because almost 10 insurance companies have now approved this therapy, many patients are able to afford this therapy now. Thank you.
Thank you, sir.